Okay, we are 2 minutes past 5:30. So I'm going to get us started. Welcome everybody. My name is Daniela Miranda. I'm EOLWA's Community Outreach Manager. Um, Once again, welcome to our 2024 annual meeting. We're very happy to have you joining us tonight. And I'm just going to get us started with some Zoom reminders and housekeeping, which you can see on your screen. So you may have noticed that you were muted upon entry. And again, as I just mentioned, that's because we have so many people joining tonight, which is wonderful. But we would really appreciate it if you could stay muted so that we can listen to our featured speakers. You're welcome to put your questions in the chat as we move through our programming tonight. And a staff member will either answer it as it pops in, or we will direct it to the speaker during our Q&A portion of the meeting. And just so you know, we'll have plenty of time at the end of the meeting for questions and answers. And during that time, you are welcome to unmute, although that might get messy. So let's prioritize that chat tonight. We have also enabled closed captioning, and that means that you should see subtitles at the bottom of your screen. If you can see them or if you would like to turn them off, please go to the bottom of your screen, click the button labeled CC, and choose to enable or disable closed captioning. And this meeting will be recorded so that it can be shared with newsletter subscribers and audience members sometime next week. We are doing our best to spotlight only the speaker. So technically you shouldn't appear in the video unless you're speaking. But if being recorded makes you uncomfortable, you're welcome to turn your video off. And with that, I am going to move on to our land acknowledgement. This is something that we as a community like to do at the start of our meetings. So we would like to start with an acknowledgement of the traditional and stolen lands that we reside on. End of Life Washington maintains a statewide presence, which means that we live, support clients, and work to educate individuals in the ancestral lands of 29 tribal nations. In addition, EOLWA recognizes the Duwamish, Wanapum, and Chinook tribes working for recognition by the U.S. federal government and that have a long history in present-day Washington. To acknowledge this land is to recognize the history of physical and cultural genocide and settler colonialism, which continues to displace and shorten the life expectancy of Indigenous people today. As we coexist in this era and in this work, we ask you to join us in a moment of reflection on how we benefit from occupying Indigenous lands, how we can educate ourselves and take action about the state-sanctioned violence and the other struggles that Indigenous peoples face, which we may have the privilege to be unaware of, and how these violence create barriers for Indigenous and other underrepresented populations who are seeking access to death care. So we invite you to reflect on these 3 points on your own time, hopefully after the meeting. With that, I'm going to stop sharing my screen and hand it over to our first set of featured speakers tonight, our co-executive directors, Casa Sutherland and Alex Grams. Take it away.
My name's Alex Gramps, and I'm one of the co-executive directors for End of Life Washington. Thank you so much for joining us today, just 2 days after the election. This election's been especially charged, and we deeply appreciate you giving us your time and attention today, even though so many of us are so worn out. We really appreciate you being here with us. Before we begin, we'd like to take a moment to acknowledge that we're here championing the right to a good death when there are so many people across the world for whom a good death is completely out of reach. I'd like to invite you to take a moment of silence with me to acknowledge the incredible hurt happening across the world, as well as the deep privilege we hold in those of us who qualify having access to the right to a planned and peaceful death. Thank you for joining me in that. I'd like to share a little about who we are and then give you a quick overview of End of Life Washington's accomplishments and challenges in 2024 and our plans for 2025. So End of Life Washington's board implemented a co-leadership model in late 2023, and CASA and I were hired into the co-executive director roles starting in January of this year. We have both been working for End of Life Washington for 4.5 years, and we've seen both the organization and our state's medical aid and dying access evolve considerably over that time. We had the unprecedented achievement of receiving state funding for the first time in the organization's history this year. While we are applying for further state funding, we predict it's unlikely more will come through, and we're so grateful to our incredible donors for continuing to make this work possible when state funding is not always an option for us. More doctors than ever across the state are supporting their patients and using medical aid in dying, thanks to the tireless efforts of our medical director, Jess Kahn, and our volunteer medical advisor, Bob Wood. They're constantly out there providing coaching, resources, and education to help providers learn how to provide this care at an excellent standard. Financially, as an organization, we're becoming more stable year by year. We have a healthy reserve and ended last fiscal year in the black. Even with the state funding we received this year, we're still 80% funded by individual donors, and we're in absolute awe of the generosity and determination of our donors who give to us in any amount or who name us in their wills. You are what make this work possible. As always, as more people around the state learn about Death with Dignity and our services, the need for support continues to increase faster than we can grow to accommodate it. We are constantly breaking records in the numbers of new clients we receive, even as hospices across the state are providing more and more of this care. We are so proud of this team, of the incredible volunteers who provide this care, and of the hospices who have partnered with us to expand their services and support medical aid in dying. And still, the need continues to grow. Over the coming years, we will keep working to educate more providers and make medical aid in dying education part of mainstream medical education in Washington state. We'll support and encourage more hospices to adjust their policies and provide more medical aid in dying support. We'll train more volunteers who can support clients and their families in navigating the process of using this law. We've come so far, and we are not going to stop. We're incredibly grateful that you're here fighting this fight with us. Thank you so much for being here.
Thank you all for being here tonight. Thank you, Alex, for starting us off and for that much needed moment of silence. My name is Casa, and I am proud to be with you tonight as one of End of Life Washington's co-directors. I'll admit that I don't really feel like I have the right words, but what I am certain of is that I will always stand for a world where humans have their rights, autonomy, and care that they deserve. And I'm really glad to be here with all of you tonight. Tonight, we're here to affirm autonomy and choice at the end of life. As Alex said, we've made incredible strides, and I'm really excited to share with you the progress that has been made this year, and I'm incredibly proud of all of what we have done. We believe that end-of-life care, including aid in dying, should be part of the standard practice of care. We can and we are normalizing death and death care. This last year, there have been more conversations about end-of-life choice than ever before. End of Life Washington has had a group of volunteers this last year answering the phone with a human voice on the other end. Let us continue to be a compassionate ear to the thousands of callers that reach out each year. I've been so humbled by the number of providers, loved ones, and volunteers that are showing up to care for people. This year, we have seen members of our own community, early advocates for choice in death, now use the same law they worked to help pass 15 years ago. Hundreds of providers are supporting their patients have access to medical aid in dying, and many of them, if not most of them, are calling and consulting with Dr. Jess Kahn and Dr. Bob Wood on how to navigate the process. There have been presentations across the state given to the public and to healthcare partners about end-of-life choice. There are more volunteers than ever before bedside at death, with a new cohort of End of Life Washington volunteers also joining us this fall. The fact that 18 hospices across our state are providing MAID services to their patients is absolutely extraordinary. The intention of Senate Bill 5179 2 years ago was to increase access, and we are seeing the success of that. Provider education, including ANRP and PA education, is occurring, and they're supporting their patients with this care. Aid in dying medications are being delivered across the state, reducing the need for clients to drive many miles. More eligible terminally ill adults are getting access in Eastern Washington. It is the region of the state that has seen the most growth this last year. In the Tri-Cities of Eastern Washington, 2 hospices changed their policies to provide MAID services. And in addition, End of Life Washington was involved in the advocacy efforts to help Multicare, a secular hospice, open in Spokane County, where later next year they will start providing medical aid in dying to eligible clients. Together, we've reduced barriers, expanded access, and empowered individuals to take control of their own end-of-life care. And we must continue. There are entire care deserts across Eastern Washington where there are limited end-of-life services. People deserve compassionate care in life and in death. And End of Life Washington will continue to be part of the effort to build better systems of care. Next year, you will see us continue to educate, to train, and to advocate for our rights for choice. To empower individuals to take control of their care, we are very excited about our hospice map project. Based on the Public Department of Health policies, a legislative change we help shepherd, where we are creating a public map. This map will outline what hospices cover what counties and what MAID services they offer. We hope to be able to release this map in the early spring of 2025. We have been collaborating and networking more, increasing our presence at conferences from Seattle to Spokane and Dublin to Chelan. I have had the privilege of being in the room at a lot of these conferences and have learned a lot, but what I have felt most commonly is appreciation. To work for this organization and with you all. We are a model of end-of-life care in our nation. And in these conferences and in these conversations, we have begun mapping the next horizons of our advocacy, how we will expand access to choice for people. Other countries are showing us pathways to autonomy with safeguards in place. I assure you all that we are not going to stop working towards the future that preserves human rights. Our progress is only just beginning. Yesterday, I began to wonder in earnest what the fight is going to look like to keep this right. Yesterday, I anxiously watched West Virginia vote counts. They were voting on a state constitutional amendment to outlaw medical aid in dying. Unfortunately, by a count of 6,000 votes so far, they outlawed and forbid aid in dying. This is terrifying. And here we are, lucky to be in the state of Washington for most of us, where we have had the right of a planned death for 15 years. This year alone, our volunteers have been bedside for 250 deaths and have supported 943 clients. This work must continue. In the last 2 days, we have seen a huge surge in requests for support. We've been slammed with calls and emails, and here we are. We are all showing up when it matters most and will continue to do so. It's a moment and a call to action, and here you are. Thank you. We wish to stay in connection with you and build community with you. Tonight, you're going to hear stories of incredible progress from some amazing people and speakers, and you're in for a treat. Thank you for being part of the End of Life Washington family. Daniela, I'll send it back to you.
Thank you, Casa. And we are just going to, before we move on to the rest of our featured speakers, take a moment to introduce you all to EOLWA's new board president, Cindy Nover. Cindy, I'm going to just hand it over to you so that you can introduce yourself.
Hi, thank you, everyone. I'm Cindy Nover, and I actually brought my mom here to this meeting tonight, which is why my lighting is a little weird and I'm sort of sharing the space with my mom. She's here from California and is a supporter of what we do, but perhaps not from the same political side that you might expect your supporters to come from. So I'm trying to expand access as we've been talking about, even here in my own home. So sorry about my lighting, but I'm happy to be here. Like Daniela said, I'm the new board president. I come from Eastern Washington. Washington. I live in Eastern Washington, and we're not exactly the care desert that Casa mentioned in this region near Spokane, but Eastern Washington is very underserved in terms of medical aid and dying type services. Personally, I'm a licensed clinical social worker, and I worked with a hospice who directly told their patients that this was not something that they wanted to support them with. And that really lit a fire for me. I'm an advocate at heart, and I really wanted to learn more about it. And shortly thereafter, I had a personal friend who was dying of cancer and could not access services through his providers here, his oncologist and other folks would not provide him information. He had to arrange a provider on the west side of the state in order to access MAID services. And so that was just another thing that inspired me to continue to be involved. I also I worked for the state, and a few years back, 5 years ago, the state provided me an attorney to do my estate planning. And my attorney that was given to me by the state said medical aid in dying is not legal in Washington state. I almost fell out of my chair. I had already had these experiences, and then this was who the state was giving me to be my estate attorney. That's this person's area of expertise. And so, I mean, so many things on a regular basis remind me that we need to expand access. And while the client services that End of Life Washington provides are near and dear to me, I work in the space to an extent. Our advocacy is what I'm most proud of, and I'm really happy to be the first board president in Eastern Washington. I enjoy hearing more and breaking some stereotypes around Eastern Washington about whether or not this is legal and how one can access it. And I'm just so proud to be part of this organization. And I'm glad that you allowed me to speak here tonight, and welcome everyone. Thank you.
Thank you, Cindy. Okay, so moving on, our next featured speakers are Dr. Jess Can and Dr. Bob Wood, and they are here tonight to tell us about MAID integration into medical systems over the last 15 years. Take it away, please.
So I guess I get to go first. I'm an internist by training, and I was one of the local leaders in the AIDS epidemic, and got involved in 1982 and had lots of experience in helping people die, and really developed in that period a strong interest in how doctors could be more helpful. In 2008, Washington passed the Death with Dignity initiative. Nearly 60% of the voters supported us. It's still surprising to hear some people say that Death with Dignity is available in Oregon, but not in Washington. So we have a bit of education to do. At that time, back in 2008, all medical societies countrywide were opposed to Death with Dignity. When I retired in 2010, Rob Miller, who was then the Chief Executive Officer of Compassion and Choices of Washington, which we've now renamed End of Life Washington, recruited me to take over from Dr. Tom Preston, who had provided physician leadership to the first Death with Dignity initiatives. My roles were to provide medical advice to volunteers and staff, to work with and educate and support willing physicians, and to find physicians when patients' own physicians refused to participate. Tom provided me a list of physicians who'd been supportive and who were willing to participate for clients whose own physicians were unwilling. Gradually, I expanded that list, but often it was inadequate to meet the needs of all of our clients. And sometimes clients would die before we could find willing physicians. No hospices at that point were willing to provide participating physicians. And actually, that persisted up until about 3 years ago, when one hospice finally decided to get involved. In 2016, when barbiturates, which were the main drugs that we had used to help patients, became unavailable or prohibitively expensive, with the help of two wonderful physicians, Doctors Terry Law and Carol Parrott, we worked together to develop a new set of drugs, lethal drug protocols that later got modified by Lonnie Shavelson down in California into the regimen that we currently use and is sort of the standard across the country at this point for what we now call medical aid in dying. Dr. Shavelson also founded an academy of medical aid in dying in 2020, just before the pandemic got going. And he has provided, and the academy has provided a lot of support for physicians, not just in California and Washington, but countrywide, as more and more states have adopted medical aid in dying. And the Academy has now created a journal adding to the credibility of Death with Dignity efforts. Jess is very much involved in the Academy. For nearly a year, beginning in 2020, we had a wonderful licensed volunteer medical director, Dr. Wayne Dodge, whose life was cut short following a tragic accident. And it was, I think, after that we realized we really needed a full-time or at least a part-time medical director. And in 2022, we hired our first paid medical director, Dr. Jess Kahn, as to expand our volunteer physician network and to provide hospices willingness to participate in qualification activities. This year, Jess's position has increased to full-time, greatly relieving aging me. In the past few years, the Washington, Oregon, California, and Massachusetts medical societies have at least become neutral on medical aid in dying. So great progress in the last few years. In 2023, End of Life Washington spearheaded revisions to the Death with Dignity Act to remove barriers to medical aid in dying, allowing licensed mid-level care providers like nurse practitioners and PAs to participate in qualifying patients, and considerably shortening the waiting period for qualification from 15 days down to 7 days. So great progress has been made in the 14 years that I've been involved. And I'm really glad to turn it over now to Dr. Jess Kahn, who is our full-time medical director.
Thank you, Bob. I'm just so grateful to be in this virtual space with all of you today. And yeah, it's definitely needed to be in communities like this right now. So thank you all for giving up a portion of your Thursday night to be here. I think continuing on with the story that Bob and I are telling, I think this is one of showing an arc of transition and of progress in our state. And I know for myself, I personally trained at a Catholic Associated Residency program in Oregon. So although they certainly had their own Death with Dignity law at the time I trained, I was not trained at all or educated about, anything regarding that, even though I was definitely a supporter even back then. And I only became involved with medical aid in dying because back in 2017, when I was working as an internal medicine hospitalist down in Southwest Washington, people would ask me about this option and I would try to help them find out who could do it for them. And at that time, there was no one in the whole corner of Southwest Washington that was willing to prescribe the Death with Dignity medications. And so ultimately, I decided that I was somebody, and if nobody else would do it, then I guess I could. And that's what I did. And I remember feeling extremely intimidating, knowing that this is something so important and I wanted to get it right, but I didn't really know what I was doing. And I had never been formally educated or trained, and I didn't feel like I had a lot of support. And luckily, I was able to connect with Dr. Lonnie Shavelson down at that time, and he became a really strong mentor for me. And I felt like I could reach out to him with any sort of question or weird, concern that I had, and I felt really supported by him and by Thalia as well. And I remembered that that helped me a lot. And so, you know, even at that time, my colleagues in Southwest Washington expressed a lot of general support for the idea that patients should have the access to medical aid in dying, but they also felt like they didn't have really any training, education, or support to participate on behalf of their patients. And so they just didn't. So that kind of was the state of things for several years in my life. In 2022, I had the extraordinary luck to become part-time medical director for End of Life Washington. And I've seen tremendous growth in that time in the number of providers who are willing to help their patients by participating as either the prescribing or consulting provider for their death with dignity process. I make sure to let all the providers know that Bob and I are always here. We're absolutely happy to talk with them by phone, by text, by email, however we can to support them, and that no question is too small to come to us with, because I know how important that level of support was for me, and I want all the providers, you know, in the state of Washington to feel like they have that same level of support from Bob and I. So I will say that I think it was last fall, the Washington State Medical Association went to head, oops, sorry, covering the camera. The Washington State Medical Association met to consider whether they would change their policy from opposing to neutral regarding medical aid in dying. And it was a long and somewhat boring process, but ultimately they did go ahead and make that change and became neutral, which was great. We were happy for that change. But I will say that during that time, there was polling of the, you know, the association's members across Washington state, and it was almost 70% of the membership that was supportive of medical aid in dying. So I think we've gone from a place where, when this law was initially passed back in 2008, I think the medical community was very hesitant and very concerned about potential, you know, risks and how it might be abused. And I think we've come a long way to see that the medical community has really grown to see that this is a legitimate part of end-of-life care. I will say that hospice medical directors and providers are more and more coming to the conclusion that participating with medical aid in dying is not only part of their duty, but also that they think that the hospice model really is uniquely structured to be where people get the best quality of care for those who want the option of medical aid in dying. And so they have started more and more to participate, which is wonderful. We were recently able to attend the Washington State Hospice and Palliative Care Coalition Conference, and we were able to talk with a lot of providers who expressed, you know, support for providing comprehensive end-of-life care, including the option of medical aid in dying via a hospice team, which is absolutely where I think that we should go with this. As I believe Casa mentioned, we've gone from having just a very few number of hospices that even offered any amount of medical aid in dying services to now having 18 hospices and counting who allow their providers to participate as either attending or prescribing or consulting or both. And that means in just one short year, many hundreds of terminally ill Washingtonians are being cared for and offered comprehensive end-of-life care services, including medical aid in dying, within the context of their hospice team. This includes hospices in underserved areas of the state, such as Yakima, Tri-Cities, and Spokane very soon, as Casa mentioned. So we're very excited. We're very grateful to our hospice colleagues. I think this is the wave of the future, and I'm so excited that that's where we are going. Our efforts last year to update the law and require hospices and hospitals to publicly disclose their medical aid in dying policies has helped patients to make an informed decision about where they want to receive hospice care. We are working on creating a map, which will be available on our website, and will make these decisions and policies even more accessible, which empowers people to make the best decision for their end-of-life care. Another working project we have is to create a general educational video that we will give some information about our law and how the process works and how to participate. And we plan to embed this into palliative care curriculums across the state for training programs such as medical schools, PA schools, nurse practitioner schools, nursing schools, social worker schools, really anyone that has touching the healthcare system, we want them to come out of their training programs with a baseline knowledge of medical aid and dying and of our law, so that they can go forward into their working careers and have that understanding already. I feel incredibly fortunate to work with the people who are extraordinarily caring, giving, and motivated, not by money, but by what seems to be the right thing to do. And as we review where we have been and where we are now, I'm hopeful that the future will bring, and I'm motivated as to work as hard as possible to contribute to the vision to make sure that medical aid in dying is an accessible option for all those who want it. I thank all of our supporters here for making our work possible, and to our volunteers, as we cannot do any of this without them, and they inspire me every day. So thank you all for being here, and I hope that we can share a little bit of hope in this time where there's a lack of it.
Thank you, Jess and Bob. That was wonderful. Okay, so next up, we are going to hear from Amy Hamlin. A little bit more about MAID integration into palliative care over the last 15 years. Take it away, Amy.
Hi, everybody. Thank you so much for inviting me to speak. Tonight, I'm going to talk about the journey my husband and I went through. My husband, Randy, was a palliative care doctor at Harborview and an ICU doctor at Harborview for decades. He was diagnosed with ALS in 2021, and at the end of his ALS progression, towards the end, he opted for medical aid in dying in February 2023. I've been asked to speak about palliative care. I'm not a physician myself, but I've certainly learned a lot about it, living with him for 25 years and working as an advocate. About Randy. Randy led a brave and generous life. As an ICU doctor, he worked to provide people with the best medical care possible, which when necessary included the best death for patients who were dying. As Dr. Wood said for himself, Randy trained as a resident during the HIV epidemic. He witnessed horrific and traumatic deaths firsthand. He knew these sick people deserved dignity, compassion, and excellent care during their final days, as did the families who were profoundly suffering with them. But he saw at that time, the healthcare system lacked the expertise to guide them through their trauma. My husband felt that the then emerging field of palliative care provided a more patient-driven and collaborative approach to care decisions. Now to clarify, I've heard a lot of confusion around the understanding of palliative care, and so I want to talk a little bit more about it. Palliative care is frequently a misunderstood aspect of medical care. Many people tend to think of it, talking about palliative care, it signifies death, and they will reject it even when it could help them through their disease progression. Palliative care is focused on improving the quality of life for people with serious illness and their care partners. Palliative care is adjacent to traditional medical care to provide comfort at any point after diagnosis. Its key elements are managing symptoms effectively as possible, ensuring that medical issues and treatment options are understood by the patient and their care provider, their caregivers, and that all of this information is effectively communicated at all times. And the care care that's provided by the whole care team is coordinated and not siloed, as we often find it is. Palliative care strikes to empower patients and loved ones to be more fully informed and participatory in treatment options, and to make the medical arena less opaque and formidable when illness is already stressing people so incredibly. So for Randy, March 21, he was diagnosed with the most aggressive form of ALS, bulbar onset. As many of you know, ALS is a disease that ravages the ability to control muscles, bit by bit, affecting movement and breathing, as the person is left to wait, ultimately inert, as organs shut down, bringing death. That is, unless a trauma, such as a lethal fall or a choking incident, happens first. For Randy, who had experience working with ALS in the hospital, the prospect of his own ultimately becoming totally immobile and bedridden, dependent on others for all of his needs, living apart from family, tethered to machines, and just waiting as this gruesome illness continued to assault his body, this did not seem like living for him. We had discussed this all even before his diagnosis, and again, as he watched his mother, she had had polio her whole life and was bedbound and had to live in a care facility the last 2 years of her life. This was not something that he wanted to be looking forward to. So early in his career, about the time that we got together, we were talking about this. Randy had lost a healthy and dear friend to suicide, and he was skeptical of what was then, and most unfortunately termed, physician-assisted suicide. But in time and over the course of his practicing, he very much came to respect medical aid in dying as something wholly different than a suicide, as it is medical aid in dying is not the impulse of an otherwise healthy person. Rather, medical aid in dying is a premeditated choice that can enable a person who is already being killed by a terminal disease and near death to take control, to end their own unbearable suffering, and bow out with dignity. Randy came to appreciate medical aid in dying as an ethical part of the physician's role to support their patients when they're facing death, to honor their final wishes with compassion and respect, and to ease suffering, even at death. Randy had become an advocate for more study, research, and quality improvement around medical aid in dying long before his own illness. So within a year of his own diagnosis, ALS had taken his speech, and throughout the following year, his mobility and autonomy. He said that every day was harder than the last, always hard day. When the test revealed his symptoms and weakness were progressing very rapidly, his doctor gave him a prognosis of 6 months or less. He started hospice at home, so meaning that his medical care would now be solely comfort care. He also applied for the option of MAID, did the required paperwork, that is, required meetings with the doctors to confirm that he knew what he was doing and he met the legal requirements. The prescription was prescribed, and it was ready whenever and if ever Randy felt it was time. A volunteer from End of Life Washington came to our house and described what the process would be like and answered all of our questions. And this knowledge was a huge relief to Randy and to me. Thank you, Carl. As hard as Randy fought to go on living, within a few weeks into hospice, he decided he just couldn't go on, and he died at home with medical aid in dying. Medical aid in dying allowed Randy to choose compassion for himself, to end his own suffering, and to die quietly at home with loved ones. And it showed compassion for our family, as it allowed our daughter Alice and I to be right there, laughing, crying, holding him, surrounding him with our love as he gently eased into his final rest. As our daughter, then 19, said, Randy was able to take control of his death when ALS had taken everything else away from him. We were terribly brokenhearted to lose him, but his death arrived with more dignity and peace than trauma, and for that, we are supremely grateful. I had another experience around the same time, losing my brother. He had been, his disease arc was very similar to Randy's. He had been diagnosed with stage 4 cancer, and after a couple of years became drug resistant. He told me that he didn't his biggest fear looking at the end of his life was the experience of dying by cancer. And at his last oncology appointment, I was there when the oncologist talked about medical aid in dying. I saw him visibly relax. His option of utilizing medical aid in dying clearly and significantly reduced his anxiety and allowed him to focus on what was important to him at the end, his son, his friends. With MAID, Steve died peacefully, surrounded by the love of family and friends. These two wonderful men with very different diseases, very different levels of pain and existential suffering, personal to each of them, they both chose to die on their own terms. Now, this is National Caregiver Month, and I was a caregiver, so I'll add my own little piece. Several months ago, I was working with my therapist about my difficulties dealing with the grief of losing my husband. I said, even after nearly a year, I felt traumatized. She asked me to think about where the trauma itself lay. Was it the diagnosis, the disease progression, the death itself, or the period after his death, having lost him? And I thought hard about this. I realized that the trauma that haunted me was confined to the 2 years of the disease progression itself. His death by medical aid in dying was peaceful, and by the time he was ready to go, it felt merciful. Randy's passion was to mitigate, to palliate suffering for his patients through the course of their illness. We who love Randy are certain he would want other dying people similarly positioned to know about and have access to the option of MAID. To that end, our daughter Alice and I have given talks around the country and written pieces for national publication, advocating for better knowledge of and legal and logistical access to the option of MAID for terminally ill people who are near the end of their lives. I'm delighted to hear from End of Life Washington about the progress that's been made in the last 2 years since I lost my husband. When he first applied for hospice, and the hospice found out that he had applied for medical aid in dying, they denied him. And that's not the case anymore, and I'm very delighted to hear that. I want to just close with the words from journalist Diane Rehm. Her husband had Parkinson's, I believe. He was ineligible to take MAID because it was illegal there. And instead, he opted to withhold hydration and nutrition to die. It took 10 days. She says, quote, "We are all just one bad death away from supporting medical aid in dying," unquote. Thank you so much for having me here. Thank you for your support of medical aid in dying and the work you're all doing.
Thank you so much, Amy. And I will just mention, that Amy is the co-author of the article, The Strength It Takes to Suffer, and we will be sharing that link later on in the chat and in our follow-up email that goes out with the recording. And before I move on, just a gentle reminder that you're welcome to put questions in the chat as we move forward. We will have just a dedicated Q&A section as well, but in case you're worried about forgetting and so that we can start getting to some of them ahead of time, we just wanted to remind you of that. Okay, so last but not least, we're going to hear from Connie Brum, one of our very long-time volunteers in Eastern Washington. So take it away, Connie.
Hi, thanks, Daniela, and thank you, Amy. This is a very hard act to follow, but I'll do my best. My name's Connie Brum. I'm a volunteer client advisor with End of Life Washington, also an ambassador and a sometimes consulting physician. My comments are relevant to the vast area of the state that we call Eastern Washington, but I recognize that there are equally rural areas west of the Cascades, so hopefully my comments will represent them as well. There are several events that have affected access to medical aid in dying in Eastern Washington. I can only speak to changes since I became a volunteer in the fall of 2019, not the whole last 15 years. I was introduced to one VCA in Spokane, 90 miles away, and told that every clinical visit took place in person, preferably with 2 VCAs, of which there were precious few in Eastern Washington. I drove to Spokane way more often than I wanted or ever intended to. And then COVID. And we were all introduced to the miracle of Zoom. Suddenly, I met some amazing people who I otherwise would never have known, and from whom I was separated quite vastly geographically. Our monthly Zoom team meetings brought mentorship and camaraderie to a small group of widely separated VCAs, keeping us energized and involved through the pandemic. More importantly, it became possible, even necessary, to meet with clients by phone, and over time to communicate with clients and their families by phone, email, and text. This made it possible for me to support far more numbers of clients over a wider geographical area than I would ever have been able to before. The use of Zoom also provided a way for volunteer providers to meet with clients from great distances and provide support and access to people who otherwise would have not had a chance at finding prescribing providers. The option of remote visits has also created an opportunity for our team to have 2 volunteer physicians on our side of the state who do all of their visits remotely, sometimes from as far away as Mexico. One more benefit of the age of Zoom has been in education and outreach. Our monthly end-of-life ready presentations have attracted people from all areas of the state to learn about their end-of-life options and the ways that they can interact with their healthcare team. This is often information they're not getting directly from their providers. And then, of course, here we are together tonight through the miracle of Zoom. Okay, enough about Zoom. The most recent major milestone to affect rural Washington was the update of the Death with Dignity Act in July of 2023, which others have already referred to. Expanding providers to include PAs and ARNPs has most likely doubled access for patients who have very little access to MAID through their personal physicians. A large percentage of providers in Eastern Washington work for the Catholic healthcare systems and are prevented from participating in MAID. And where our team primarily uses our 2 remote access volunteer physicians, we now have a PA in Spokane who is also a VCA and is able to see clients in the Spokane area who have difficulty with technology or remote access. So if you're here tonight, thank you, Cody. The update to the law has also given pharmacists the ability to ship prescriptions. This has made my job easier, improved access for patients, and reduced cost. Prior to this option, there were only 2 consistently participating pharmacies that I was aware of in all of Eastern Washington, one in Spokane and one in Wenatchee. I spent hours begging the pharmacists in Pullman and Clarkston to provide prescriptions, even though they had done so in the past, but it was exhausting. So having this option of shipping has also lowered the cost for patients. In Spokane, the total cost is $800. In Wenatchee, it's about $750. And we've also begun using a pharmacy in Kent where the cost is about $600 total. And patients now don't have to drive 100 miles or more to pick up their prescription. Finally, I'd like to mention that over the last 2 to 3 years, I've done educational programs in Yakima, at Chaplaincy Hospice in the Tri-Cities, at Gentiva Hospice in Spokane Valley, and at the Hospice of Spokane on 2 different occasions. Daniela and the team have also done several more. I think this has paved the way for Jess to encourage Chaplaincy Hospice, for example, to provide more direct services to MAID, and I'm glad that effort has finally been successful. And recently, we've received many new clients referred by various staff people at Hospice of Spokane. This is a 2-edged sword because it's a volume we're having trouble keeping up with. We've had a recent request for support in the Spokane area, but at least they've come to us with mostly accurate information. I'm hopeful that the increased exposure and collaboration with Hospice of Spokane will lead to increased direct involvement on their part. Baby steps, but we are moving forward. And that's all I've got, so I'll kick it back to you, Daniela, and I'm happy to entertain any questions.
Thank you so much, Connie, and thank you again for being here. Connie's joining us after volunteering all day at the polls on Tuesday, and she's exhausted.
Oh yeah, I forgot to mention, Daniela and I live in Moscow, Idaho, where we still vote in person.
So thank you so much. I know you're tired. Okay, folks, so we have gotten to the point in the evening where we're just going to open it up for questions, and you're welcome to unmute at this point. We're also answering questions in the chat as they come through, and you're definitely welcome to direct your questions to specific speakers or just in general to End of Life Washington if that's easier. And maybe we can stop spotlighting so that we can more easily see if people unmute, and please be patient with us. We have 120 people in the room, so it can take us a little bit to figure out who's trying to speak. But please go ahead. Still looking, still looking. And if I don't see you and you don't see anybody else speaking, please feel free to just go for it.
Daniela, can I just address something that we've been kind of doing in the chat, but I think just to make sure everyone's hearing this information as well. There was a question about what kinds of progress are we making in long-term care facilities? I think that's been an issue for many people where they've been told that they can't take their medical aid and dying medications at a facility where they live. And I will say that we have made a lot of progress. We have been working closely with the governing bodies of all the long-term care facilities, whether it's ALF or, assisted living facility, adult family homes, or other long-term care facilities. And we do have a very strong law here in Washington State that protects the rights of people living in long-term care facilities to be able to have full access to their rights under Washington law. And of course, medical aid and dying is a right of theirs under under Washington law. And so that's just not widely known by the facilities. And so often it's just a matter of re-educating them, bringing them up to speed. But if you ever have a case of somebody that's being told that they can't take their medications in their long-term care facility, please reach out to us and we will help to advocate and make sure that that is not a barrier for them.
Thank you, Jess. Okay. And to kind of follow Jess's lead, just to make sure that everybody's seeing what's in the chat, we do want to say that VCAs are volunteer client advisors. Sorry, we do love an acronym. And those are the folks that support individuals one-on-one across the state when they're trying to access medical aid and dying. And I see Teresa's hand. So Teresa, go for it.
Thank you, Daniela. Sorry, I'm not camera ready, but I have a question about the map that you are planning to publish in the spring. Can you give us a little bit more context about what has gone into that and what you hope to achieve by publishing that?
Thank you, Teresa. Jess or Casa, do you want to take that one?
I can start us off. So part of the changes we made 2 years ago was, as Jess said, every hospice and hospital has to make their end of life, especially medical aid and dying policies public. And beyond that, the Department of Health actually, End of Life Washington was a stakeholder, but we helped create a one sheet that basically laid out the services provided around medical aid and dying and asked hospices to let us know, or let the Department of Health know, what services they provided and which ones they did not. Then Jess primarily has been following up with all of these hospices. Those paperwork were due at the beginning of this year, and many of it is still missing. And she's following up one-on-one and asking, hey, is this right? Have you updated your policies? And what we're doing is any hospice that is offering medical aid in dying services has gone into a spreadsheet with checkboxes indicating what services they offer. Do they have an attending provider, a consulting provider? Do they allow their staff to be in the room to mix the medication? Can they witness the written request? All parts of medical aid in dying process. And we are working on creating that spreadsheet into a public-facing map where people can filter and search what hospices are in their county and what services they provide. We understand that it's really important that people are able to choose care that matches their values. And so to be able to see that and choose hospices based on their values of care is where we're hoping this goes. I would also just add in addition to that is I think it holds the possibility to even have more information provided about hospices, like in the future, are they able to support VSED or not? And there's a lot of expansion that could be seen in this map. I don't know, Jess or Alex or anyone wants to add more to that?
I might chime in that I think this map will be really helpful, not only to the clients, but also to physicians. Most referrals to hospices are made by physicians, and many physicians still are not very familiar with medical aid in dying. And sometimes they may refer to, say, Providence Hospice, which is a Catholic organization. And being a Catholic organization, it won't provide providers to qualify patients for medical aid in dying. And we're having our volunteers actually say to the patients, our clients, would you consider switching to a hospice that provides services? And that actually puts pressure on some of the other hospices. I don't know that we can pressure the Catholic hospices into helping us, but a number of hospices, I think, are seeing that if they don't provide this service, they may not have the clients that they need to have in order to be successful.
Thank you. Oh, Jess, go ahead.
Yeah, I just think to say more about the map a little bit more, we'll get on to other things here soon, but I think the, information is power, and it's been really, really hard for people up until now to know, whether it's the people, the sick people themselves that are choosing a hospice or their family members or loved ones, or whether it's the providers who are making the referrals. It's been hard for them to know, who is supportive, who offers services, who can't participate because of organizational policies, et cetera. And so, the first step was getting the law changed and having a legal requirement that these policies are made public. And that was a really great thing that happened last year. And then second is compliance, which and slowly but surely chipping away at and trying to get people to actually now turn in the forms, and then, making something that's actually user-friendly. Right now, the forms that are available publicly, but not in any sort of format that people could actually use because it's all just a list of policies. You'd have to sort through them. So having a map where people will be able to come, say, I live in, whichever county, and then have a list pop up. Okay, these are the hospices in your county that offer some level of medical aid and dying service, and which ones, and how to get in touch with them, et cetera, et cetera. So it's really just about empowering people to make the right decision for them based on what's out there.
Thank you, Jess. And Judy, I see your hand. I just want to get to some of the questions in the chat first. Casa, do you mind answering Jocelyn's question about whether we provide support for VSED, voluntary stopping of eating and drinking?
Yeah, absolutely. So as it was said in the chat, voluntarily stopping eating and drinking is legal in all states. It can be difficult to navigate for a client and their loved ones. End of Life Washington does not provide bedside support during the VSED process. We provide support in the planning and prep and how to build your community of support and get caregivers or doulas or hospices or where to do VSED. and how to build out that collective of folks to support you through that process. There's also been incredible work in the last year, not by End of Life Washington particularly, but some great advocates with End of Life Washington that have created a new voluntarily stopping eating and drinking directive that is linked on our webpage, and would highly recommend that be a directive everyone fills out who may at some point be interested in voluntarily stopping eating and drinking or eating and drinking by advance directive. It's a great new resource that came out this year. We have been more involved with more VSED clients over each year. We're seeing that growth actually outpace our growth for MAID. There are still very few clients. To give you an idea, last year there were 29 clients who reached out to End of Life Washington for VSED volunteer support, and I expect that number to be even higher this calendar year.
Thanks, Casa, and I'm going to put you on the spot again. To answer Shelley's question, will we be advocating for greater than 6 months to die?
That's a great question. I pause because I don't really know where we are as a country in terms of our Supreme Court and our ability to expand aid in dying laws right now. There is some discussion that there are plans to take aid in dying laws to a Supreme Court ruling, which may overturn our right on a massive scale. That would be horrendous and not anything we can even plan or prep for, but we are talking about it already. But we are looking at what, that is kind of looking at the national climate we exist in is an important part of this, as well as looking at the state climate we exist in. On a state level, we have elected basically a supermajority in our state and have said no on all of the initiatives that would lower funding in our state. There is pathways forward to expand access for medical aid in dying. There are many countries that have given us good outlines for that. It is definitely something we are talking about and exploring. We have a lot of education to do with our own representatives and senators about what that would look like, because we would be the first in the nation to do so. California tried to do this last year. And unfortunately, we're shut down by even the national aid in dying organizations at this point, with the idea of expanding aid in dying to be more than somebody with just a 6-month prognosis. I said in my speech, like my individual dream, absolutely. I will push this as fast as the organization, the state, and the country can go. And where we can go with it. I do believe, and we all believe, that we want people to have access to choice, and that is where we will continue to put our efforts.
Thank you, Casa. And Judy, go ahead. You're welcome to unmute.
Thank you. Thank you for taking my question. I did put it in the chat too, so just ignore that one. So I'm a senior and I live in Pierce County, and we're experiencing a lot of our care, even in hospice care, that is being owned and operated by Catholic facilities. And they have put a lot of restrictions on the care that we can get. So I'm concerned that that someone that doesn't know anything about this service will not be able to even hear about it. If they're getting their care from a Catholic or a Catholic affiliated organization. And I also heard that if they do ask for the medical aid in dying while they're a patient, that they will be discharged from the service. Now, they may be incorrect, so I don't know how that works, or if the end of life would come in and bring a physician that would assist the patient. So how can end of life help with these barriers and denial of care? And I'm concerned about other places in the state where they only have Catholic affiliated, and this service is not available to them. So I appreciate you answering those questions, and thank you so much.
I think there's a couple of things, you bring up some really good points, and these are definitely concerns that we all have of people not even getting information, not being offered this as an option when it is a valid option to them. And the educational efforts are definitely continuing on all of our fronts. I think one thing that I'll point out is that in 2020, there was a law passed called the Protecting Patient Care Act, and it was directly regarding abortion and death with dignity laws. And so it said that no institution, whether they are Catholic associated or whichever, but no institution can bar their employees from giving accurate information about legal options in the state of Washington. So there used to be a real big culture of fear, and it still persists in some places about, even talking about this as an option. But since that law was passed, and I make sure to always say, mention this law whenever I'm talking to medical staff, that you really shouldn't have any fear about talking about this, and even making referrals and even documenting their first request. That's all allowed explicitly in this Protecting Patient Care Act, as well as the updated Death with Dignity Act law from the updates we did last year. So that's still not widely known in a lot of places, but it is absolutely the truth. Organizations can bar participation, but they cannot bar speech, and they cannot bar discussion of a legal option in the state of Washington. So that's part of it. And then, the other part of it is we're still here. We're still, going to be providing support, whether it's if people are in places where they can't find, providers to participate, if they need the volunteer support to participate. Not every place that has a hospice that is willing to provide any level of, services for medical aid in dying. And that's where, we will definitely step in to make sure that people have this option and have the best support that they can. So.
And I might chime in that we've had lots of clients who have been enrolled in Catholic hospices, and we do our best to find providers for them. Sometimes, as I indicated earlier, we'll ask them to consider switching to a different hospice. And although some patients are reluctant to do that, it's actually quite easy to do. But we provide volunteers to people in Catholic hospices, and we will find 2 willing providers to qualify them for death with dignity. And we actually get a lot of referrals from Catholic hospices. The staff aren't permitted to participate, but many of the staff refer cases to us. And I just want to reassure you that even in Pierce County, we can make sure people have access to death with dignity, even when they're in a Catholic hospice.
And I will add that when there are moments of advocacy that we see, like last year, there was a bill to prohibit or to give more oversight to healthcare mergers. End of Life Washington is participating in making sure that we can prohibit as many mergers as possible and keep our healthcare as secular as possible where we can. We have not heard any cases. There was a question in the chat of, have healthcare professionals been punished for providing this information? They had in the past. In the case of Washington, in the last 2 years, we've heard no cases of healthcare professionals being punished for providing this information. It is illegal under the law to punish a healthcare professional for providing this information. We have not heard, I do not know of cases where people have been let off of services. There continues to be an amazing amount of barriers to getting accurate information or to getting information that points you in the right direction. So we are still seeing barriers to access in these restrictive healthcares, not with everybody, and there is still lots of work to do there.
Connie, yeah, you want to add one more thing?
I just wanted to add that Daniela and I have received several requests from Catholic hospices for education, which we have done. So there are lots of people that work for these institutions that are very pro-choice and very interested in getting accurate information to their clients and making appropriate referrals. And that at least is a step forward. And I think the more of that we can do with other Catholic institutions, may help.
Thank you, Connie. And Shelley, we see your question, but Lisa has their hand up, so go ahead.
Hi, thanks. This is a process or administrative question, I guess. And it relates to the 6-month issue. Are there standards that physicians adhere to? You know, because there are opinions about different things and length of life. And, you know, I mean, there may be studies that say, you know, you can anticipate this, but I mean, is that an appealable decision? How does all of that stuff work? Thank you.
I know Bob, Jess, Connie.
Yeah.
Yeah.
I think yeah, you're making a good point that there are shades of gray and areas of subjectivity in everything, but including the area of prognostication and telling people, you know, how much longer we expect them to live. And very frequently we are wrong as, you know, healthcare professionals. We are wrong when we try to predict anything, especially in this realm of prognostication. So, you know, typically when our providers are, you know, making sure that we're following the law, we're trying to rely on someone with some level of expertise to make that determination. So if it's a cancer patient, you know, it may be an oncologist giving that 6-month or less prognosis. If it's, you know, a neurologic disease, their neurologist. If they are on hospice, which we encourage all of our clients to be on hospice, you know, having the hospice medical professional that has assessed them, you know, make sure that they do meet the criteria to be on hospice, and that includes that 6-month or less expected prognosis. And there are many people who, of course, outlive that 6 months prognosis, and as long as they're, you know, doing okay, we're glad for that to be the case. And so, you know, the question really is just, if the disease were to follow its normal expected course, would they be expected to die within 6 months? And so, yeah, there is subjectivity. There's no hard and fast rules. I think the question of whether that can be appealed is a case by case basis in terms of, you know, what's going on, what has happened, who has assessed them. And certainly we try to give everyone as much possibility as we can. If they're wanting the access to the option of medical aid in dying, we want them to have it. And so we try to make sure we explore every avenue for them to make sure we can see if they qualify or not. And usually if the answer is they don't qualify, the answer is just not yet, because everyone's terminal eventually. So, you know, the answer really isn't a no, it's just a not yet, and we keep assessing.
Well, Jimmy Carter's fooled them all, hasn't he?
Okay, and Shelley, you asked, what about public hospitals in taxing districts? And we were hoping that you could elaborate a little bit on that. Just so we give you the best answer possible. And you're welcome to mute if that's easier.
Yes, this is Shelley. What I meant was, like, I'm in a small taxing district, a hospital, and I'm just wondering if the doctors that are associated with those hospitals, I don't know how many there are around the state, has there been any issues come up about that? I remember when they were looking at doing a merger of our hospital, and the issue came up, merger with a Catholic, I can't remember what kind of hospital, it was probably Catholic, but the issue came up about abortion. But what didn't come up was the issue of medical aid in dying. And there was no merger that ever happened, but can a public hospital allow or disallow their physicians from participating beyond education?
So I don't know the full answer to that question, Shelley, but I do know that I recently was in Snoqualmie, which has a public hospital there in Snoqualmie, and I gave them an educational, they asked for a presentation. Their doctors and providers there were very interested in providing medical aid in dying. And they told me that as a as a public hospital, that they were required to offer medical aid in dying. Now, of course, each individual provider has the right to opt out, and that is by law, and we certainly support their right to do that. But in general, it sounds like from what they were telling me, and again, I'm not an expert on the policies of public hospitals, but from what they told me, public hospitals, have to offer legal, all the legal options of per Washington law. And so it sounds like medical aid in dying is something that it falls under that. But I think it's tricky because, of course, they may not have providers at every hospital that are willing to do that.
So
You have-
can I have a follow-up question since I'm on? Especially given the political climate in the Northwest right now. Oregon just now allows out-of-state residents to participate in medical aid in dying, and I don't think Washington does yet. Is that an idea that's being worked on? I'm thinking like the Idaho residents, for example.
Yeah.
Border.
Because Oregon has no residency requirement, it hasn't been something End of Life Washington has prioritized to pursue. And in addition, becoming a resident of Washington is not hard to do. We get people coming into Washington to access this law every year, even from Idaho. What is required is you are registered to vote in Washington. You either have a driver's license in Washington, or you have some sort of lease agreement showing that you have a place that you're renting. That latter one is often quite easy for people to produce, and is that intention to stay a resident has been used by quite a few people to access the law in Washington.
Thank you.
Before Canada had the laws that permitted medical aid in dying, we actually had a number of Canadian citizens come to Washington, establish residency, and use the medical aid in dying law. So we get people from Florida and Texas and other places that don't have the law. One point that I think we need to work on and haven't achieved very much yet is that the only hospital I'm aware of that actually permits medical aid in dying on premises is Children's Hospital here in Seattle. And that's interesting because you have to be 18 in order to qualify for death with dignity. But about 5 years ago, there was a young fellow, I think 14 years old, developed osteosarcoma, terrible disease. And he became 18 while he was still dealing with the disease, and the doctors continued to care for him. And he would have been able to use medical aid in dying as an inpatient at Children's Hospital. But he, in fact, died before he finished the qualification process. So I think it would be useful for us over time to try to expand to allow actually patients to use the law while inpatients. I don't see any legal reason why that shouldn't be possible, but it's a barrier that is a difficulty because we actually find the two docs for the patients and complete the qualification process maybe while they're still inpatients. But then we have to have them discharged from the hospital to actually take the meds somewhere else. And that's clearly a barrier and difficult for patients to have to deal with. The other problem is that there is no requirement for doctors to tell people who are terminally ill that medical aid in dying is an option for them. Until medical aid in dying becomes a very common procedure, the law says that they don't have to tell patients that this is an option for them. So that's another fairly substantial barrier when people don't know that they could have this option.
Thank you, everybody. And I see what is going to be our last question because we're quickly coming up on time. So Tom asks, have you discussed varying levels of dementia? Tom, I assume you mean in relation to medical 89, but please correct me if I'm wrong. And you're welcome to unmute if that's easier. Yeah, and I think Rachel is asking a related question, which is there talk of allowing early Alzheimer's patients to qualify for MAID rather than having to suffer for so many years? Rebecca answered that Oregon has allowed people to start VSET and then qualify for MAID in cases like this. But our waiting period here in Washington is too long for that. Casa, anything you want to add?
Yeah, I can add to that a bit. People with dementia and Alzheimer's are often reaching out to End of Life Washington. They are an incredibly fast growing group of people and are deserving of all the same care that everyone else gets and the same access to choice, in my opinion. There is no state in the United States that allows dementia or Alzheimer's patients to qualify under the law in their early to mid stages. I do hope that that is something that we can look at in the future and advocate for. I think it is needed. I got into this work with a dad with dementia who wanted to use medical aid in dying. I always have my sights on how we could include this population in our medical aid in dying laws. There are a lot of examples of countries doing this well and a lot of examples of countries not doing this as well. So part of the work of being at these conferences over the last year is learning some examples of other countries that have integrated dementia as a diagnosis into this care and how they have done it and how it is working and how it is not. What I think is interesting is just recently when I was in Dublin, I was talking to 2 providers from Canada who do allow dementia and Alzheimer's as a qualifying diagnosis under the terms of their law. And I asked them how often somebody with dementia or Alzheimer's comes for this option. And they said it is about 1 in 500 of their patients has dementia and Alzheimer's, which is really nothing in comparison to the amount of requests that we are getting to open up this law for people like this. What I think is also very interesting there is I wondered for many nights while I was at this conference why that could be. And I think I finally landed on it is possible that Canada's healthcare is taking care of people in their life and in their life with dementia differently than the United States is, which is meaning that there's not so much tax on the families or the loved ones with that type of diagnosis. So I think when I said we want as good of life, care in life as we do in death care, it's really important to keep an eye on those type of things as we look to expand the law.
Thank you, Casa. And thank you everybody so much for your questions. I am just going to move us into our closing remarks, but a reminder that if you have any lingering questions, you can always email us or reply to all those emails you've been getting from me as well, and I'll direct your question to the appropriate staff member. Krista is putting some links in the chat that we want to share with everybody. We will also share those in our follow-up email that will go out with the recording next week. Just again, to thank everybody for being here. We would like to close the meeting just by spending a few minutes thanking everybody in our community. EOLWA would not exist without the help of volunteers, staff, board members, and supporters. So if you would like to help us strengthen this community, please consider becoming a volunteer. Our next recruitment cycle will start in early 2025, so stay tuned for those dates. You can also consider donating or signing up for a newsletter. And if you're a provider, we're always looking for volunteer providers as well. It truly takes all of us working together to protect Washingtonians' access to end-of-life choices. So thank you so much for being here tonight. Thank you to our speakers and our staff and to all of you for just taking time out of your evening. to be here in community. Thank you and have a good night.
Thank you.